Hello everybody. So today we are going to discuss this case of posterior circulatory stroke and our series of stroke lecture. So today we'll see the definition and the pathophysiology of the stroke and how to evaluate. So we have this 39-year-old male patient with no known comorbidity. He came with chief complaint of vomiting since afternoon when he presented, associated with the giddiness and sweating. So he came here for the further evaluation. So on arrival, his pulse rate was 89, blood pressure was 174 by 100, respiratory rate was 20, saturation was 97. Then cardiovascular examination, S1, S2 present, RS, air entry equal on the both side. PA per abdomen examination soft, non-tender, CNS E3, V5, M6, and the patient was drowsy. So he was shifted to ICU in view of low GCS. Patient was intubated in view of low GCS, and CT was taken which showed bilateral cerebral infarct with hydrocephalus with midline shift. So these are the investigation of this patient, and this was the MRI. We can see the ADC image, and this pink portion indicates the area of the stroke. We can see here this large posterior portion of the brain is involved. So this patient was diagnosed as the posterior circulatory stroke, same MRI. So we have started him on the antibiotics, this anti-epileptics. Then dual antiplatelet support was given in the form of ecosprin, anticoagulation in the form of Clexane, and in view of raised ICP, we have started him on mannitol. So eventually, patient underwent this posterior fossa decompression craniotomy with Clark's duroplasty. Now we'll see what is ischemic stroke. In 1970, WHO defined stroke as rapidly developed clinical signs of focal disturbance of cerebral function lasting more than 24 hours or leading to death with no apparent cause other than of vascular origin. So, what are the major risk factors for stroke? Well documented modifiable risk factors are hypertension, diabetes mellitus, dyslipidemia, obesity, body fat distribution, physical inactivity, and tobacco use. Structured cardiac disease such as rheumatic valve disease, atrial fibrillation, sickle cell disease, carotid stenosis, excessive alcohol consumption, unhealthy diet, and the nutrition. And the less well documented modifiable risk factors are migraine, metabolic syndrome, drug abuse, obstructive sleep apnea, hyperhomocystinemia, hypercoagulability, elevated lipoprotein, inflammation, and infection. Non-modifiable risk factors are genetic factor, increased age, low birth weight, race, low socioeconomic status, and male gender. Now, the acuity of stroke. Hyperacute stroke refers to the first several hours after stroke has occurred when thrombolytic therapy may be indicated. Labeling suggests the use of recombinant tissue plasminogen activator in applicable patient within 3 hours, but this has expanded to within 4.5 hours and it's supported by scientific statement from American Heart Association. So beyond this 4.55 hours, extending typically for next 1 to 3 days is acute period during which care directed at maximizing worsening or recurrence is paramount. Following this, the subacute period extends through 2 weeks after the event and is often characterized by attention to rehabilitative efforts. Beyond this point, the period is known as chronic period, and the rehabilitative effort continues. And it is mainly focusing on optimizing long-term secondary preventive therapy. Now the anatomical territory. The true broad clinical anatomical categories of intracranial vascular disease syndrome are specified based on the division of cerebrovascular supply into those areas supplied by the carotid system, that is anterior circulation, and those supplied by the vertebral vascular system, that is posterior circulation. So neurological symptoms are attributed to hypofunctioning, hypoperfused brain tissue from vascular occlusion, and those commonly encountered with the carotid system disease include aphasia, monoparesis or hemiparesis, monoparesthesia or hemiparesthesia, or monoocular vision loss. Symptoms commonly encountered with vertebral bacillus disease include hemianopia, cortical blindness, diplopia, vertigo, dysarthria, ataxia, limb paralysis, or paresthesia. Sensory motor dysfunction is frequently contralateral to cranial nerve dysfunction. Loss of consciousness or vertigo typically occurs with other vertebral bacillar symptoms, and they are rare in isolation. Other isolated symptoms such as diplopia, amnesia, dysarthria, lightheadedness usually do not serve as a basis for diagnosis of vertebral bacillar disease. However, association with other brainstem symptoms may support this diagnosis. Now, what is the underlying mechanism? Acute intracranial vascular disorder is the vascular disorder and can be categorized as being due to large vessel thrombosis, small vessel thrombosis, it may be cardioembolism, and other known etiology or stroke of undetermined origin. Large vessel atherothrombotic occlusion is caused by atherosclerosis in carotid and the vertebral bacillar arteries, and it includes intracranial atherosclerosis. Large vessel disease is the common cause of intracranial vascular disease. The pattern and severity of neurological deficit depend upon the arterial territory and completeness of occlusion and extent of collateral flow. Now, what is small vessel arterial occlusion? Small vessel arterial occlusion occurs frequently due to lipohyalinosis of lenticulostriate striate arteries or basilar penetrates, and it results in the small area of cerebral infarction called as lacunae. If lacunae occurs in the internal capsule, thalamus, or pontis, substantial neurological deficit may occur even with small lesion. The most common lacunar syndromes are poor motor hemiparesis, poor sensory loss, ataxic hemiparesis, and dysarthria clumsy hand syndrome. The typical presentation of cardioembolic stroke is with maximal deficit at onset, although small minority may have stuttering clinical course. Diagnosis may be difficult when the patient has coexistent cerebral atherosclerotic stenosis, since as many as one-third of patients with cardiac embolic source have another potential explanation for their stroke. The most common cardiac sources associated with the cerebral embolic events are outlined in the table. Uh, So the patent right to left cardiac shunt have been recognized by the contrast echocardiography with increasing frequency among younger patients with stroke. In the absence of hypercoagulable state or atrial septal aneurysm, patent foramen oval is not considered significant risk factor for cardioembolic stroke, with up to 25% of healthy population noted to have patent foramen ovals. Now, these are the risk factors. These are the cardiac sources of embolic stroke, and the common are non-alveolar atrial fibrillation, acute anterior wall myocardial infarction, ventricular aneurysm and dyskinetic segments, rheumatic valvular disease, prosthetic cardiac valve, right to left shunt, bacterial endocarditis. And less common are mitral valve prolapse, cardiomyopathy, bicuspid aortic valve, atrial myxoma, non-bacterial endocarditis, mitral annular calcification, idiopathic hypertrophic subacute subaortic stenosis, and atrial septal aneurysm. The aggregated category of other known etiology includes rare causes and distinct from the other categories. These include traumatic or spontaneous extracranial or intracranial arterial dissection as an important cause of stroke in patients under age of 50. Thrombophilias, where congenital or acquired, are more likely to impact venous system, but may be unusual cause of artery occlusion, including ischemic stroke. The border zone infarction is caused by diminished cerebral blood flow resulting from cardiac arrest or systemic hypotension and often associated with cerebral arterial stenosis resulting in focal infarction and deficit occurring in well-described pattern of end arterial distribution between major vessels. For the carotid circulation, a border zone infarct occurred between distribution of middle cerebral artery and either anterior or posterior cerebral arteries. Stroke of undetermined etiology or cryptogenic stroke is diagnosed after full evaluation for other known cause has been unrevealing. This entity is associated with better outcome than the stroke of other categories and require treating clinician to do comprehensive evaluation when the cause of stroke is not apparent. The subset of cryptogenic stroke include those in patients with embolic stroke of undetermined source. These patients typically have the pattern of infarction consistent with embolism and have completed an evaluation to exclude other causes of ischemic stroke. Now, the differential cause, symptoms suggestive of intracranial vascular disorder may mimic symptoms of other neurological entities. An important distinction between the ICH and intracranial vascular disorder. A symptom more suggestive of ICH, such as early obtundation, coma, seizure, headache, vomiting, are known to be insufficiently reliable to make diagnosis because similar presentation may be seen with the ischemic stroke. Condition other than cerebrovascular event can occasionally cause acute focal neurological deficit and must also be considered. Primary or metastatic brain tumor and hemorrhage into the tumor may resemble stroke. Now, SDH may rarely present with the acute focal neurological deficit and must be considered for elderly patients, even without a history of head trauma. Patients with migraine headache sometimes develop focal neurological symptoms either before or during early phase of headache. Rarely, this deficit may occur in the absence of headache or headache that is acephalic migraine or may persist that is migrainous infarction. Patient with focal seizure may develop sensory, motor, or aphasic symptom that can mimic intracranial vascular disorder, although they are usually stereotypical and transient. Occasionally, focal neurological deficit may follow seizure and persist for 24 hours or longer. This is known as Toad's paralysis. An important, uncommon, reversible cause of acute focal neurological deficit is hypoglycemia, which should always be assessed before any aggressive treatment is initiated for presumed ischemic stroke. Similarly, among young patients or patients with psychiatric history, objective neurological signs or corroborative radiological evidence must be established to avoid treating functional paralysis with relative aggressive therapy. Finally, worsening of old deficit should prompt metabolic or infectious evaluation because the damaged region may act as a locus minoris resistantly with the focal clinical worsening of chronic deficit. Computed tomography and MR imaging can identify brain tumor, ICH, and SDH. Diffusion weighted MRI sequences are abnormal in acute stroke and typically normal among patients with migraine, transient hypoglycemia, functional weakness, seizure, Toad's paralysis, and circumstances attributed to worsening of old ischemic deficit. Now, lab and radiological evaluation. A comprehensive workup to determine stroke uh, severity and to identify the possible multiple risk factor is important to determine effective treatment option. Urgent imaging help in differential diagnosis and is a key in protocols for therapeutic intervention with recombinant tissue plasminogen activator. Both CT and MR based imaging studies of brain are reliable and sensitive means of differentiating between intracranial vascular disorder, hemorrhage, and other mass lesion. Now, the vascular imaging such as CT angio, MR angio should be performed to define vascular territory involved and guide reperfusion treatment. When CT angio or MR angio cannot be obtained to image craniocervical vasculature, carotid artery ultrasound and transcranial Doppler studies may provide anatomical and physiological information of intracranial and extracranial vessels. CT perfusion and MR perfusion studies can help guide intravenous or endovascular therapy for equivocal or uncertain cases. CT is typically faster and is more readily available and does not require patient screening for contraindications such as metallic or electrical implants. However, MRI is more sensitive than CT for identification of brain tumors, and MRI can identify infarction at early stage, that is after several minutes of scanning. So this MRI-based diffusion-weighted imaging has an important bearing on acute stroke diagnosis and treatment. Selected cases of suspected intracranial hemorrhage with equivocal and negative finding on CT, MRI may detect subarachnoid, subdural, or intraparenchymal hemorrhage. And electrocardiogram should be obtained to assess possible underlying and concurrent cardiac rhythm or ischemic changes. Two-dimensional transthoracic and or transesophageal echocardiography and telemetry and Holter monitoring should be done routinely because patients often have more than one potential underlying pathophysiology and cardiac structural and rhythm abnormality may change the treatment approach. Transesophageal echocardiogram should be considered for patients under 50 years of age, that is the patient with enlarged left atrium, and for cryptogenic stroke patient of all age. For patient with embolic stroke of undetermined source, prolonged ambulatory telemetry or loop monitoring may identify additional patient with covert atrial fibrillation. Routine serology, including complete blood count, partial thromboplastin time, prothrombin time, comprehensive blood chemistry, chest radiograph, erythrocyte sedimentation rate, syphilis serology, and urine analysis should be opted. When thrombolytic therapy is being contemplated, the blood glucose, PTT, prothrombin time, and platelet count should be obtained immediately as a point of care test. Fasting lipid profile, homocysteine, C-reactive protein can be obtained by day. Other studies include anticardiolipin antibodies, hypercoagulable testing, serum protein electrophoresis, and fibrinogen should be performed for patient age 50 years and younger. And for patient with history of cancer, recurrent deep vein thrombosis, or family history suggestive of autosomal dominant pattern of stroke. Lumbar puncture is typically restricted to those for whom diagnosis of subarachnoid hemorrhage, meningitis, and cerebral vasculitis is suspected. For such a patient, large ischemic stroke with cerebral edema or mass effect, lumbar puncture is delayed until the risk of herniation has resolved. So, EEG may be helpful when associated seizure activity is suspected. Thank you.